Well, it's my pleasure to be here today, and thank you very much for inviting us all to present on the topic of HealthLinks and the HealthLinks approach to coordinating care. I just want to also introduce, although she's not going to be presenting today, my colleague who is instrumental in helping me advance this across our region, and that's Marcia Gibson. She's here in the front row. She's also a senior integration specialist at the LHIN. So to advance the slides, we'll just press there we go. So today we have really 4 objectives to present today, and that is to build awareness and knowledge of the HealthLinks approach and the benefits of the approach to patients and providers. We want to increase the understanding of the role that care providers can play in the HealthLinks approach. And we're here to also seek your collaborative partnership in supporting this approach for patients who have the most complex needs. We'll end the presentation by giving you some information about where we're going with HealthLinks in the future. So to start, we'll just give you an overview of what the HealthLinks approach is. The initiative was started by the Ministry of Health and Long-Term Care in December of 2012. As a voluntary initiative to improve the coordination of care for those people who have the most complex needs in all of the regions across the province. The HealthLinks are geographically situated, meaning that they are spread out across the province. Right now there's 84 different HealthLink areas, and within our region there are 10 HealthLink areas at present. Providers were asked to come together on a voluntary basis to look at some innovative ways to manage and coordinate care among care teams that are supporting these people. And the idea was to reduce fragmentation of care, to improve the patient experience, and to also help to sustain our health system and make better use of healthcare resources. So why start with the most complex patients? It seems like a difficult place to start, but really these people have the most fragmented care, have the most number of care providers looking after them and working with them, and they're having difficulty moving through the healthcare system. In addition, when you look at the proportion of patients and the cost to the healthcare system, this is really where it's really evident that if we do a better job, we may also make better use of resources. So if you look at the population pyramid, you can see that the top 5% of the patient population is actually utilizing about 65% of our healthcare resources. So who is the target population? At present, the target population for the HealthLink approach to care focuses on people who are living with 4 or more chronic or complex conditions. And within that group, there's been an identification of some subgroups or more vulnerable groups within that, and those are people who have mental health and addictions challenges, people who are palliative, and also people who are frail. Now, when we're identifying, or anyone is identifying a patient who may benefit from this approach, there's also other considerations to take into account. And that is that people may be living with social and economic determinants of health that are impacting their ability to manage their own care. They're also high users of healthcare services. And of course, you would use your own clinical judgment if you obviously know your patients the best, and if you see that they have multiple conditions and they would benefit from this approach, then that, of course, is brought into the mix. The Ministry of Health and Long-Term Care did a data analysis of the and listed the selected conditions populations that would fit within this target population. About 98% of them of high-cost users have at least one of these conditions. So I know it's hard for you to see at the back, but there's a list of 53 of them on here. So what is the HealthLink approach? HealthLinks is a patient-centered approach, and we're all familiar with that. We all work in a patient-centered way. But what is different is that the HealthLinks approach is driven by the patient's own goals, and that that we're trying to create a seamless coordination of care by ensuring that each person has their own coordinated care plan, that all the providers who are working with them know about and know the patient goals, and that there's ongoing care coordination among the care team members. What's interesting is that many of the patient goals go beyond medical or health needs. They often go into looking at providers that are outside of the healthcare system, including people in, say, housing or social services. So they would be part of the care team as well. We do have a performance measurement framework that we use for HealthLinks, and there are currently 2 mandatory performance metrics that we're reporting to the ministry. One is just sheerly the number of people who are receiving coordinated care, so we're counting the number of coordinated care plans. And the other is the improvement of access to primary care, because primary care providers, either the physician or nurse practitioner, are a key part of the care team. And right now we're looking at the ensuring that every HealthLink patient is attached to a primary care provider. So the target for that is 100%. If we can reach that, I think we're at about 95%. There are a number of other indicators as well that we're tracking, that more system level impact indicators that we're currently in the process of defining how we're going to measure that, because it involves looking at multiple databases to try and pull that information out. Hopefully this year we'll have more information on that. But last year, that was the, we almost pretty much had all of our HealthLinks up and running at that point. And we decided to look at what is the patient profile of the people that we're already seeing, and can we see that there's been any impact on this approach. So I just thought I would give you a quick summary of some of the patient profile highlights of 724 individuals who had coordinated care plans at the time. So in terms of identification of where people are being referred from, the majority of people are referred from the community, and within that 61%, 40% of those are coming from primary care providers. A little over a third are coming from within the hospital, and then at the time a much lower percentage coming from home and community care, formerly called the CCAC. In terms of age, the majority of the people that were seen last year were seniors, so 45% were over the age of 75, and a little over 23% between 65 and 71. But you'll see that there's a fairly large percentage of people that are also between a younger age group of between 19 and 64 years of age. There were more women than men, and the language distribution is fairly similar to what we might expect in our region. So when you look at those vulnerable subpopulations, about 4% of the patients that were enrolled last year were palliative, 12% could be categorized as frail seniors, and a pretty large proportion of people, about 40% of the people, had one or more mental health condition, the most prevalent being depression, anxiety, and addictions. The most frequently cited physical, mental, and social conditions that the 724 people had, I just thought I would list them here for you to take a look at. I'm not going to read through them all, but it's probably those that you would expect of people who are the most complex. The other thing we looked at was the distribution and the number of care team members, because part of the HealthLink approach, which is really important, is to identify who are the members of the care team, or who are the health or social service providers that are supporting these people, and how many are there, and then how do we coordinate and increase the communication among that care team. So this is from last year, and you can see there's quite a distribution, but we think that coming up over the next year, when we have more data, we'll see this distribution change a little bit. But you can see that there's quite a number of people working with individual care team, with individual patients. So as I said earlier, one of the key performance measures is improving patient experience. Well, how does that happen? I'm just going to read this because it comes from the information that we're getting through patient stories and through our patient experience surveys. that the patient's journey through the health system is improved through number one, more effective communication among with their care providers. Secondly, they have more involvement in decision making, and they have a focus on their own goals. So this is really about the patients feeling listened to and working on small steps towards better management of their own care. So just in summary, what's different about HealthLinks? Because we're all looking after patients very well. I think everyone is doing a great job in supporting patients in the work that they're doing. But what's different about the HealthLink approach is that, number one, it's a defined population. Two, the patient and caregiver are very much engaged in deciding their own goals, and they are an integral part of the care team. Three, primary care providers are involved in the care team. There is one plan that's based on the patient goals. The care team is connected, so people that are working with that patient know what's going on. And finally, providers who work outside of health, community and social services are there to also support the patient. So that's kind of in a nutshell what the HealthLink approach is. And what I'd like to do now is I'm going to actually introduce both of the next speakers at the same time. The first speaker that's going to come up to talk about the HealthLink approach in a little bit more detail, when I say care coordination, there's actually a pathway that's taken, and Dasha is a great person to give you that information. She is the project manager with the Central Ottawa and the Southwest Ottawa North Grenville HealthLinks. She's a passionate advocate of client-centered, strength-based approaches to providing care. She previously worked at the Canadian Mental Health Association in Ottawa, where she was a manager of the housing outreach team, and has a background in working in court outreach and with Ottawa Mental Health Court. She has 10 years of frontline experience working with complex and vulnerable populations, and holds a master's degree in psychiatry from McGill and a bachelor's in criminology, law, and sociology from Carleton. This is what I find really interesting. She was also the captain of the Carleton University varsity basketball team. I love basketball, so that really caught my eye, and has won numerous awards for that. Ellie will be our next speaker after Dasha, and she's going to provide a case example for you. She has a master's in social work and is a registered social worker. And for the past year and a half, she's been employed by the Arnprior Region and Ottawa West HealthLink as a care coordinator and a care coordination coach. She has 26 years experience as a social worker here at the Ottawa Hospital Rehab Center, and 6 years as a social worker in community psychiatry. She's trained in mindfulness-based cognitive therapy and has facilitated several groups for people with brain injuries and social anxiety. So I'm going to call up Dasha first.
Thank you, Karen. Hello, everybody. So my portion of the presentation will focus on two things. I'm going to talk about why there is a need to do HealthLinks approach, and how are we doing HealthLinks approach. So most people with many healthcare needs see a lot of different people for support. It can be hard for patients, clients, and their families to arrange appointments, travel to appointments, and keep all the information straight. It can be extremely difficult for service providers to understand how they each best support people with many care needs. And I can certainly relate to the last point, because for many years, as Karen said, I was that service provider whose full-time job was to navigate the extremely fragmented healthcare system with my clients. I think the image down below nicely says how we actually really, how we do great individual work in our own sectors, but we don't always provide a care in a most coordinated way. So the HealthLinks approach to coordinated care planning promotes shared understanding of what is most important to the patient through the establishment of coordinated care plan, inclusive of clear roles and responsibilities for each member of the patient's care team. And how I interpret this slide is that the patient in the middle is actually the expert of their own lives. They're the director of the helping process, and all of us come together and provide support of those goals and needs. So there is a HealthLink coordinated care pathway that's been developed, and it's used by 84, I think Karen, you mentioned 84 HealthLinks across the Ontario. But if you're like me and I look at this graph right away, I go, ooh, this looks a little too complicated. So we tried to really simplify the process to show you that it's actually not that hard to do HealthLinks. So it includes 5 steps, and they all seem to actually begin with the letter I. So 5 I's. It includes identification process. It includes invitation and engagement. It includes initiation of a care plan, information sharing and including others in a form of a care conference. And the last point is it time to transition. So let's look at it briefly. Identification process. So anyone can identify a HealthLink patient, and we actually had numerous self-referrals as well. HealthLink criteria of 4 or more chronic condition and social determinants of health has to be met, as Karen mentioned. The patient who have multiple service providers would be probably the best suited for HealthLink's approach, but as Ellie will actually showcase later today, her case did not have many providers involved and still very much benefited from a HealthLink's approach. With the patients okay, you would use a standard HealthLink identification form. We try to stay away from the word referral because you're actually identifying people for HealthLink's approach. You're not referring them to a long-term service. You would fax the identification form to fax number on a slide, which currently serves as a central intake until some more standardized central intake is coming soon. So invitation and engagement. So once the care coordinator is assigned, he or she would contact patient and briefly describe the HealthLink's approach. They would arrange the first visit at their home or in a community, and we actually try to encourage our HealthLink care coordinators to come and start coordination process while the patients are in a hospital. It would ensure for a seamless transition from hospital to home. They would obtain verbal consent to proceed with the visit and to begin gathering information from circle of care, and of course, most importantly, from the client themselves, and answer any initial questions that the patient has about HealthLinks. So third point, initiation of a care plan. This is how a care plan looks like. I'm a huge fan of this form because as a service provider, numerous times I had to fill out the forms that were extremely deficit-based. From 0 to 5, rate a patient how unwell they do. And this is the first form. I didn't have to rate anybody. It didn't have to be my assessment of how much support they actually need. The section on my plan to achieve goals for care, I think it's the key to this entire coordinated care, as well as the section on my care team. Sometimes as a service provider, it took me 3 months to realize who else is actually working with the same patient that I was working with. And so this section ensures that all the people who are involved with the client's care could be listed there. The focus is not on completing the coordinated care plan as fast as possible. The focus is actually on developing it with the patient and based on his or her expressed goals and needs. The coordinated care plan is a living document, meaning there is not 3 of them or 4 of them. There is only one care plan, and it lives with the client. It should be updated when changes occur or revisions are requested by the patient. Information sharing and care conference. So how do we share the information? All coordinated care plans are created by the care coordinator in CHRIS. CHRIS stands for Client Health Related Information System. I'm glad that Karen actually put that in there because when I started with the HealthLinks for the longest time, I actually thought Chris was a guy. And I really wanted to meet the Chris because everybody was just talking about Chris. It turns out it's a database. And we can share information in numerous secure methods. For example, you can share the coordinated care plan, hard copy with the client. You can share it through CHRIS or HPG for those service providers that actually have access or permission to access CHRIS, and many of them now do have access to CHRIS. or you can share it through secure fax with care team members who do not. The purpose of the care conference is really to bring together patient and their care team to share information and collaboratively create and/or support their action plan with specific assignments to address the patient expressed needs and goals. The patient is typically an active participant in their care conference. In rare cases, patient may decide they do not wish to be present, and in that case, the family member or another care team member could be there and represent their goal. I had the privilege to actually attend a few of these care conferences, and the one stand out last Monday actually. A patient came to me afterwards and said, Dasha, I've never had this before, that my care team just cares about me and wants to listen what is important to me. I can't believe you guys actually took time out of your day and came here to support me. Is it time to transition? This is one of the sections which HealthLinks and Health Quality Ontario still haven't figured out how we really do this section, but it's currently in development. Ultimately, what it means that the transition happens when the patient is ideally able to coordinate their own care, and the service providers are able to maintain a patient-centered team approach that no longer requires intensive HealthLink care coordination. The care coordinated care plan is complete, care conference is organized, care team, including patient, all received copy of a care plan, and patient, caregiver, and care team members have developed clear plan how to support or achieve some of those goals. I have added a component of stages of change concept, which looks at patients' readiness for change, because I think this is a concept that is crucial for care team member to understand. So the expectation upon transition is not for patients to be fixed or recovered, because let's not forget we're working with the chronic health conditions. In summary, I wanted to talk about what is really the care coordinator's role. The role of the care coordinator would be to create a trusting relationship with patient and inspire hope. I really wish I highlighted the word inspire hope, because a lot of our folks lost hope. Develop a coordinated care plan with the patient, facilitate communication with and all members of the care team, including the caregivers, facilitate care conference, oversee progress of care plan implementation, assess progress in supporting patients' goals, engage patient and care team in transition readiness, discussion and decision, facilitate patient transitions, and support health independence. And vice versa, the care team member's role would be to identify patients, would be to contribute to coordinated care plan, participate in a care conference, work collaboratively with the patient, care coordinator, and other members of the care team to assist patient in supporting and achieving his or her goals. And they also may take on a care coordination role if a patient is transitioned. So right now you guys saw how this is done in theory, and I would like to welcome Ellie to discuss one of her case studies. Thank you very much.
Thank you, Dasha. Nice to be here, back on my old, the old stomping ground here at the TOH. I would like to present today a case that I've been working with, and I'm still working with in a monitoring position. This client I started working with in January of this year. It's a 67-year-old man. He's divorced. He lives alone in a rental unit in a small town in the Ottawa Valley. He has no adult children, few friends, and has some limited community support. His income is moderate. He's on a disability pension, and he used to work for long-term employment, and he had to retire about 7 years ago due to his health issues. And independent in ADLs and IADLs. So his health issues, COPD, he has hypertension and dyslipidemia, anxiety and depression, and a long history of alcohol addictions. This gentleman was, or still is, but not to the same extent as before. He really, when I started working with him, he was very socially isolated. There were issues with his housing. The housing, he has an apartment. He was able to pay the rent, but he wasn't able to maintain his apartment. So the apartment was cluttered, not very clean, and he did not have the motivation and the drive to clean his apartment. He was so depressed when I met him that he really couldn't do anything. He got his groceries and his alcohol delivered to his home. He did not go outside, so from about January till April. He was connected with a relative in Ottawa by phone on a weekly basis. Transportation was an issue. His family doctor was in another town that he needed to drive to. His car wasn't working, and he just never got to go to his family doctor because he couldn't get there, even when he was invited and even when he was provided with transportation services from the local community. He did find some help for his alcohol problems over the years, and he had a couple of periods of sobriety and had some residential treatments in the past. His COPD and his anxiety really worked hand in hand. When his anxiety went up, his COPD got worse, and vice versa. So this is definitely a client that went to the hospital for many emergency room visits, because the only professional he had involved, and even community sports, was his doctor, who was not in town. So I met with him on a weekly, before I go into one meeting with him, he was identified by the discharge planning and flow nurse at the local hospital because he came through so often. So he was flagged as a person who went to the emergency room and had several admissions in that hospital. So the reason for the identification was for the client, to help the client navigating, accessing, and coordinating the care team and to support his goals. So I met with him on a weekly and sometimes bi-weekly basis in his apartment, and we started working on a care coordination plan. Initially, he was not disclosing his alcohol problem, but the longer we worked together, it became apparent, and he did mention that he had really very much a problem with alcohol and that he really needed help. Every time I saw him, he said, I want to get admitted. I want to go into the hospital. I want to go to a treatment facility. And as we all know, working in the hospital is very difficult to get admitted from home into a hospital. He did realize the impact of his alcohol use and smoking. He used to smoke a lot too, which of course is not very good for his COPD. And he really he understood that his health was deteriorating, and he was getting more and more depressed about that. So what did I do with this client? Initially, he was in such distress that my initial approach was to provide him with resources that could help him, such as the Smokers Helpline, the Distress Center, Mental Health Crisis Line. So he accepted all those resources. I gave it to him in writing with phone numbers. He never initiated calling any of them. I recommended AA meetings, which there were a few locally, which he did not go out to attend. I made a referral to local mental health counseling services, and they called him, but whenever he saw a phone number that he didn't recognize, he would not answer the phone. I linked him up with local community paramedics, and they came by a few times, and he wouldn't open the door. And so the primary care provider, I asked the primary care provider to make a referral for a psychiatrist, which was done. the referral came back stating that the psychiatrist could not see this client because he already had too many clients. In these small communities, the psychiatrist comes in once a week. So they get too many referrals and they just can't handle the caseload. I provided the client with some resources about psychologists in this area, and I also made a referral to the local addiction for counseling support. He did agree to talk to the counselor from the addiction services, and he asked me to do that together with him. So I arranged for a phone call, and she did an intake phone call with him when I was with him in his home. So we tried to look at what did I do that's so different about HealthLinks as compared to maybe what I did before as a social worker, working in the community and working at TOH. So we really looked at who is in this community that's connected, that can be an advocate for this client. And so the person that was with the addiction counseling service was really connected with residential treatment facilities in that area. So I talked to the discharge planning and flow nurse of the local hospital, and she set up a plan for us that in order for the client to get some mental health services and be admitted to a treatment facility, he had to first be admitted to the emergency department and then admitted for a day or two at the local hospital, and then he could be transferred from mental health services to a regional hospital. So that's what happened in the end. We did advise him to go to emergency one more time, hopefully, and he was admitted. And a day or two later, he was transferred to the regional hospital on the mental health unit. And they arranged for him then, after 6 days, to go to detox here in Ottawa. And in the meantime, the addiction counselor had arranged with the treatment facility that he would be admitted. He had been there twice before, and they were a little hesitant to admit him again. But because of her advocacy, he was admitted again, because that's where he really wanted to go. That was his wish. He wanted to go to that particular treatment facility. So he stayed there for about 4 months, and I saw him once, and I spoke with him a couple of times over the phone, as well as with the manager of the treatment facility. He was doing very, very well. So he was sober, and he quit smoking, and there was a complete change in his presentation and in his mood. So after 4 months, this client was transitioning back to his community, to his home. That happened in August, and early September, the client started drinking again, and he ended up in the emergency room and another admission in the hospital. The transition, I think the team that was supposed to surround him at the time really wasn't there for him when he needed it. The transition was rather quick, and before we knew it, he'd started drinking. There was a stressful event in his life, and he was back into the cycle. So during that first week in September, I did go to the hospital, met with the discharge planning and flow nurse, and we agreed that we should set up a care conference. In the meantime, we got a local primary care provider. She worked with this patient when he was on the inpatient unit, and she agreed to take him on. She was also part of the family health team. So this was good. So we had a primary doctor who was at the care conference, we had the client, we had the flow nurse and myself, and we got together before his discharge. So we got a better understanding of his goals. The primary care provider made a referral to a psychiatrist in Ottawa who has agreed that he will see this client via OTN for 2 or 3 sessions. The client has located the addiction services again, and he actually has been seen once, and he will continue to see this counselor. He's now going out of his home. I reactivated the referral to the mental health services, and they're in the process of taking him on. The client was also provided with a tonics tablet, which is like an iPad, where it's a trial that we're doing with some of our clients. So his healthcare team, he can reach the healthcare team from his home if needed, and we can do care conferences also from his home. and which is really a nice innovation that we're trialing with our clients, and which is very helpful for people who are in the rural areas especially. Because now the patient is part of a family health team, he also now has been assigned a respirologist who has already seen him in his home, and he has been assigned a nurse who specializes in the quit smoking program and who helps him with that aspect. So now he's much more surrounded by a care team, and we're hoping, he is very optimistic, he feels more supported and connected, and we're hoping that he stays successful with his goals. Thank you very much.
So hopefully that gave you an illustration of the complexity of the people that we're working with and the commitment that it takes from a care coordinator to continually build and work with the care team and some of the outcomes that were achieved. What I just want to end with is to give you some future directions of where the HealthLink initiative is going across the province and within our region. So currently, as I mentioned, we have 10 HealthLink areas across our region. All of them are seeing patients and coordinating care for those complex patients. But as you know, we are in a process now of realigning things within our LHIN and building sub-regions. So over the next while, we will be aligning our HealthLink areas to our sub-regional areas. So we'll be looking more like 5 HealthLink areas, 5 sub-regions. But this doesn't really make too much difference because the HealthLink approach, it doesn't matter where you live, it's the same wherever you live in the region. So these are kind of artificial boundaries. But you will notice over the course of the year that we may start talking about 5 HealthLink areas. The big piece is about spreading and scaling this approach. We have pretty aggressive targets to reach 10,000 people with coordinated care plans by the end of March 2019. Currently where we're at, we have about 1,800 people who now are receiving this approach across our region. So you can see we've got quite a long ways to go in the next year and a half. So we've put a lot of effort into communicating more about the HealthLink approach, to working towards a greater consistency and standardization. Because as I mentioned earlier, the HealthLink initiative started as a low rules environment where people could create things within their local communities. And that's fine because every community does have, there are differences. There's different number of providers available. The patient profiles are different. So we want to keep the local flavor, but of course there's a lot of components of this approach that are consistent and should be standardized. So over the course of last year, we've worked on a number of things to standardize the approach. The other big piece is to build the care coordination capacity in our region, because this is a different way of doing care coordination. Even the home care providers were not working in this way, although they are now. So we've got some care coordinators in home and community care that are doing this approach. We've got a number of case managers who work in the mental health sector. There are people in community support services and a host of other programs that are realize that they already work with this population and they have some experience with care coordination and system navigation that can use this, this way of working. So we're starting to build that capacity. And finally, we are doing more performance measurements. So we really want to see, as we see more patients, we want to see what kind of impact this is having. So if you do have patients that you think would fit this target population and could benefit from the approach, by all means, contact the project manager in each of the 10 HealthLink areas, and I've just put up here the HealthLink contacts and their emails and phone numbers. As Dasha mentioned, we're moving towards a central intake number, so that'll make things a lot easier for people, so you won't have to try and figure out where your patient lives. But in the meantime, if you do identify someone, there is a link on our website, on the LHIN's website, that is an interactive map, and you can just hone in and figure out what area of the region that they're in and contact that project manager. And if you have questions about the HealthLink initiative itself, please contact myself or Marcia, and we would be happy to answer any of the questions that you might have, either about how it started, what we're measuring, where we're going, any question you might have, we'd be happy to answer. So thank you very much. I hope this has been useful for you, and we're all open to questions. If you have any questions about the HealthLink approach, I'd be happy to take them.